Good evening. I want to welcome everybody to this week's happy hour session. The topic of today's session, for those of you who've had a chance to review the slides, is bigger is not always better. And we're very pleased to have Dr. Sandra Osswald hosting this evening's sessions. And she is going to be talking about conditions in which the cellular infiltrates are composed of large cells. As always, if you have any questions, I'll be checking the chat, so you can put them in the chat. Or if you're watching this later after the fact on our YouTube channel, or have questions that come up at a later time, please feel free to email me directly at tdavis@sagisdx.com or education@sagisdx.com. So without any further hesitation, I'll turn the floor over to Sandra. Sandra?
I'm Dr. Osswald, and welcome. Thank you so much for attending the next Sagis topic discussion. I'm happy to be here again. Today, we're going to talk about big cells. So I entitled this, Bigger is Not Always Better. And the reason why I did is because the residents are always asking about these big cells, and I thought I'd have a collection of entities with big cells. So thank you so much, Dr. Davis, for helping me to pull these slides for today's session. Sometimes big cells are helpful. And the most common cell we're going to look at today are histiocytes. And of course, they have this important function to remove infectious agents, foreign material like keratin, or it could be wood or other things implanted in the skin. And sometimes it serves a really good function, but other times these cells tend to proliferate or get larger, and it doesn't really help, and actually could be hurtful. And so we're going to examine different big cells today, and I hope you like it. We're going to go ahead and start with the first one, which you can see here is a beautiful punch biopsy taken for the head and neck. And when you look at it from this magnification, you can see that they're well-defined collections of histiocytes. You can see that because they look like from here, these larger pale cells, and they look a little pale because these are cells with ample cytoplasm. And let's go ahead and look a little bit closer. And you can see here, their cells are located not just in the upper dermis, but deep in the reticular dermis. And I want to draw your attention to this grouping of cells here. Here again, good collections of histiocytes. And when you look at these, you see that the histiocytes have oval nucleus and ample pink cytoplasm. So it's a typical histiocytes, but they're collecting in little groups or tubercles. This particular grouping doesn't have a whole lot of inflammation surrounding it. So we call that so-called naked granulomas because there's not a lot of accompanying inflammation. Look and draw your attention to this cell here. A number of histiocytes here have banded together into a multinucleated histiocyte. And you can see that the nuclei are lined up like a wreath along the edges of the histiocyte. And when it does, this multinucleated histiocyte is called a Langerhans type, not Langerhans, a Langerhans type multinucleated giant cell. And then if you look over here, you see another great example of a multinucleated histiocyte, another large cell. But in this case, the nuclei are not just arranged around the edges of the multinucleated giant cell, but scattered all across, like the residents say, a chocolate chip cookie. And this is a foreign body giant cell. Now, these types of cells are not unique to this entity, which happens to be sarcoidosis, but found in other entities where you have lots and lots of histiocytes. When you see somebody where you suspect sarcoidosis and you see this beautiful pathology that's consistent, you still need to do two things. One, you should polarize the material and see if you see foreign body material, because if you do, it might suggest a foreign body reaction. However, sarcoidosis can have foreign body in it as well. So it doesn't necessarily rule out sarcoidosis, and you need to do your due diligence and do your chest x-ray and ask for symptoms and review systems, etc. And the other thing you must do is make sure that it isn't a kind of hidden infectious condition. And so you may be asked to do another punch biopsy for tissue stains and for tissue culture. So this is a great example of, and I'm going to pull outward in the magnification so you can see again, and type of granulomatous dermatitis consisted of histiocytes. It's come somewhat naked, and this is just a beautiful example of sarcoidosis. Let's go to slide number 2. You can see already that this specimen is not from the head or neck. It's actually from an acral site. You know that because the stratum corneum here you see is very thickened. So let's increase the magnification and see. You can tell that the site is an acral site and there's a lateral lamina lucida. But of course, what you most predominantly see is these 2 large collections of histiocytes. In this case, very well defined collections of histiocytes with this black material. This black material you can see is probably not just intracellular, but extracellular as well. This black material is granular in nature, quite coarse, and I'm going to go closer so you can see. The histiocytes are doing a good job here. They're trying to do, and you can see here a little bit closer. Again, histiocytes, these oval nuclei with ample pink cytoplasm, but in the cytoplasm of some of these histiocytes are these coarse granulated black deposits, and this happens to be a graphite tattoo, and the histiocytes are doing their best to eat this up. To do so, sometimes they will form big cells, multinucleate cells, as a matter of fact, and you can see that here, for instance, right in the middle, multinucleate giant cells with that graphite material here that they're trying to collect and remove. Over here, look, this wonderful example, multinucleate giant cell with graphite material within the cytoplasm. So it's engulfing it, it's eating it, it wants to take it away. Looks like it has a big job ahead of them though, because it's quite a bit of material. Now this slide gives you one more nice feature which I want to show you. So I'm going to go back up a little bit in the magnification and show you that there's streaks in the tissue. Does everybody see these streaks? Many of you know that it's called knife chatter. And what is happening is the technician is trying to cut the tissue because of this hard material in the tissue, the knife is skipping a little bit. You see skipping here, 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 and here. So quite a bit. And you can see why there's a lot of foreign material here. But knife chatter is a very helpful clue to you in granulomatous dermatitis that there may be a foreign material in the tissue. So you would want to go ahead and polarize your material, particularly along the areas of chatter, to see if you find the material. Sometimes material isn't quite so obvious as in this case. So this is a wonderful example of a graphite tattoo in the body's histiocytes forming larger cells to try and engulf that and remove the material. Let's go to slide 3. I'm going to go to this slide, I believe, right here. I'm going to put this one front and center. This is a very nice example of this entity. This is a shave biopsy, and you can tell already that the skin here is more delicate, and you can see these vellus hair follicles. This is a head and neck a shave biopsy, and this is indicative of eyelid skin. And so this was a shave taken in eyelid skin, probably of a flesh to flesh yellow colored plaque or thin plaque or papule. And what you also see here are, again, histiocytes. And these histiocytes look a little different, don't they, from the previous histiocytes I've shown you. They don't have that pink cytoplasm that we were talking about. Let's look a little closer. You can see that these collections of histiocytes are lying free in the tissue. There's no accompanying fibrosis or sclerosis going on. They're lying in the tissues somewhat in a plate-like fashion. So going across the upper epidermis, the upper dermis, and you can see, let's get a little closer. What is inside the cytoplasm of these histiocytes? When you look closer, you see that these are lipid-laden histiocytes. They're bubbly, they're foamy, and they're actually called foam cells, or in this case, xanthoma cells, because they have collections of fat in them. So here's the nucleus of the histiocyte, and all this material is fat that it has collected in the cytoplasm of these cells. So clinically, again, this will look like those yellowish very superficial but thin dermal plaques located either unilateral or more commonly symmetric in the eyelid tissue. And this is called xanthelasma. Foam cells in xanthelasma may indicate a lipid abnormality, but most of you know that 50% of patients presenting with xanthelasma are normolipemic. Perhaps the younger individuals with xanthelasma may have a higher incidence of having lipid abnormality. So this is an example of histiocytes, which are lipid-laden, making foam cells or xanthoma cells, in this case, a xanthelasma. A very, very nice example. Let's go to slide number 4. I'm going to turn this way, and let's go focus perhaps on this one right here in the middle. So I really like this entity. It's a favorite of many pathologists, and for a particular reason. I think the reason I find it very interesting is because at first you may not notice that there's anything unusual about the histiocytes in this condition. They're almost inconspicuous, because the first thing you see is here's a shave biopsy. This was probably taken from the groin in this case, and you have acanthosis, right? Acanthosis meaning thickening of the epidermis. And then you also see, and there's sometimes it's more remarkable than others, but in this case, you have some mild papillomatosis. That means undulation of the surface. See how it goes up and down, up and down, up and down. It almost looks like how condyloma can look, where you have condyles of the knuckles and the intercondyle spaces. And so let's look at the top of this epidermis first. You can see here the undulations. It looks almost warty, right? Like in a condyloma. You can see these areas here which dip down, almost like an invagination, and some little focal areas of perikeratosis, and a large amount of exocytosis of neutrophils, which you can see all across the top of this epidermis, right? You all see that. Well, then, when you see something that looks viral-like, as in this case, you may want to look very carefully at the upper dermis. So let's look at the upper dermis and see if we see anything unusual. And I think already you see that there is a bluish kind of coloration, foamy cells up in the papillary dermis, not deep in the tissues, just right here up against the epidermis in the papillary dermis. If you look carefully, what do you see? All right, let's go ahead closer. And you see these beautiful foam cells again. This is the nuclei of the histiocyte, and this is the foam cell filled with lipid. This is, again, lipid-laden histiocytes. In this case, this is probably not related at all to cholesterol or lipid. It's just probably related to some kind of degenerative process of the epidermis. Initially, these were found, or these lesions, which is a Verruciform xanthoma, found in the oral cavity, and then it was found in the groin areas, and it was found now in many, many other places. And the characteristic finding, again, is a verrucous-like appearance, a warty appearance of the epidermis, and then superficially placed foam cells. So fantastic. Don't forget to look carefully. And again, in derm, we don't tend to look too close, but in this case, I think you should. Beautiful foam cells here and over here. So everybody see those? So again, a great example of an entity called Verruciform xanthoma. And what's nice with Sagis is you can go back and look at this over and over again. Let's go to number 5. Number 5, it's a little bit hard because it's cut and sectioned a little funny, or perhaps it got broken here and here. But if you can imagine, this perhaps was presented as a yellowish papule, and perhaps on a young person, yellowish papule on a child, let's say. And let's go ahead and look at this one right here. Okay, so as you can see, this is a papule, which is filled with a population of mononuclear cells and some larger cells, of course, befitting this lecture. So let's look closer at what these cells look like. And when you look carefully, you start to see mononuclear cells resembling histiocytes, but also look, foam cells again. So you can see foam cells in this entity. As a matter of fact, this entity, which is a type of xanthogranuloma, when you have a well-developed lesion, you're going to have more lipid and more foam cells. But an early lesion, you may not have many foam cells. So it makes it much harder to know what this entity is. But again, a well-established entity, a xanthogranuloma, will have more foamy cells. Now, I want to show you what some of these big cells look like, particular to xanthogranuloma, but also seen in a few other things like NXG. Here you have multinucleation of the histiocyte and foam. So everybody see that here, here, and here, but you start to see that there's a very interesting pattern to this large cell. And I would like to look, when I'm looking for this condition and looking for special cells on the edges, I look at the top of the lesion and the sides of the lesion. And I think you all can see that we're finding some very large cells in this xanthogranuloma. And this, I'm going to just show you this one because it's like the perfect example of a two-ton giant cell. What is a two-ton giant cell? It is this description given to a multinucleated giant cell with a wreath of nuclei similar to a Langerhans type, right? Do you remember the Langerhans type has a wreath of nuclei, but usually that's aligned along the peripheral edge of this multinucleated cell. But in this case, not only do you have this wreath, but you also have fat around the edges. You see how it's extending beyond the cell, so you have fat. And so when you have multinucleated cell with fat around the edges, this is called a two-ton giant cell. And a two-ton giant cell, as you can see here, helps you confirm the diagnosis of a xanthogranuloma. So this is one of those times where you drop the mic. This is fantastic. You say, thank you so much for showing me a two-ton giant cell. This is a great example. As a matter of fact, you can just, when you pull outward of the magnification, you can see so many of these large foamy cell types. And from here, right, even this magnification, you can see the formation of two-ton giant cells here, here, and here. So please go back and enjoy these two-ton giant cells. Let's go ahead and go to number 6. I really like this entity, and when I see it, I look for also a particular giant cell. And so let's see if we can find it together. They did a shave biopsy of this entity. From afar, you can see that there is a diffuse proliferation of cells here in the dermis and overlying epidermal change. Overlying this tumor is plate-like acanthosis of the epidermis, with maybe even perhaps some basilar pigmentation. You also see a finding characteristic of this entity, which is induction or follicular induction. You can see that overlying this tumor, it's almost like the creation of a new hair follicle, a little bit of a base of a follicle here. So this has overlying acanthosis with follicular induction. Sometimes these basaloid proliferations, if you biopsy this too superficial, could look like a superficial basal cell. So be very careful. If your clinical suspicion is going to be of something with a dermal proliferation, you really should make sure you either punch the specimen or do a deep shave to capture the infiltrate below. So here below, what are we looking at? We're seeing a diffuse proliferation. In this case, more of a spindled population of cells going in somewhat of a curlicue fashion. So spindled cells or plump spindled cells. The other notable feature in this area here is a lot of extravasated red cells. Very helpful. A lot of red cells. Some of you may think, was that from the biopsy? No, this is part of the tumor. Extravasated red cells and dilated vascular spaces. So let's go down and take a look at what is happening here. Here, in mixed amongst the spindled cell population, you see, again, multinucleated giant cells. We are just having fun looking for giant cells. And here, with these giant cells, some of them are a little foamy again. So now you know how to recognize foam cells, and this one has a little foamy lipid. And so these also are lipidized macrophages. However, in addition to the lipid, you are seeing also this brown or refractile brown or golden brown material. You see this golden brown material? Let's go a little closer just so you can see. See this golden brown material all across the specimen? Well, that is hemosiderin or iron, and it's coming from these red blood cells, extravasated red cells. When you have multinucleated giant cells, histiocytes, taking up iron, okay, or hemosiderin, you can call them siderophages. So these are siderophages, and when they are lipidized, you can call it a lipidized siderophage. And some people will call the formation of multinucleated giant cells in this wreath-like or ring-like structure. Okay, here comes ringed lipidized siderophages. And ringed lipidized siderophages are a hallmark of a type of dermatofibroma, here aneurysmal type of dermatofibroma. And again, if I pull back in magnification, you can see that this dermatofibroma is characterized with many large vascular spaces, aneurysmal-like spaces. Sometimes they're much bigger than this. And then you get extravasated red blood cells, you get hemosiderin, or the iron from these red blood cells. And then as part of this type of dermatofibroma, you have macrophages or multinucleated histiocytes banding together to take that up. This one does also have characteristic feature of a dermatofibroma, which are the collagen trapping. And I'll just show you, when I look for collagen trapping, I go to the edges of the biopsy, and you can see here that the spindle cell proliferation is going around the collagen bundles, making them make them form little collagen balls. So this is collagen trapping, which is another great feature for dermatofibroma. I think this is a great example of an aneurysmal type dermatofibroma, demonstrating the large cells, which we call the ringed lipidized siderophages. And I have seen on board exams a close-up, you know, for instance, you see how we're looking for here, but they go in and they take a Kodachrome, for instance, this ringed lipidized siderophage, and they show you this spindled or plump spindled cell population and ask you what the diagnosis is, and you can say that is an aneurysmal type of dermatofibroma. Let's go to 7. All right, this is another great example. I just can't believe how great the slides are that they have in this, and Dr. Davis and Sagis they have in their collection. This is probably more than a punch. It's pretty wide, right? So this is probably more like an excision, or at least an incisional from the truncoproximal extremity. From this power, you do see, again, very discrete collections of histiocytes, and they're going from the upper dermis down to the fat. This is quite extensive. And you can also see in this condition some of these linear granulomata. Do you see that? They're linear. They're almost like, again, we call them sausages. And it makes you already think of an entity, right? It already makes you think of Hansen's disease when you see linear granulomata. So we want to look close and see, is this going to be one that has multibacillary or lots of bacteria in it, or is it going to be polybacterial? And sometimes it is very difficult to see, and sometimes there's overlapping in features. So we're going to look a little closer at these histiocytes and see if they have what may be evidence or the suggestion that there may be bacteria within them. And I think you can see, like, for instance, I'm going to go really close. I know in today's lecture, we're going really close to these cells. These cells, see, this is a histiocyte, this is the nucleus, and you can see this blue-gray material. Does everybody see all this blue-gray material? Well, this blue-gray material is bacteria. This is a lot of bacteria. And when you have a lot of bacteria in the belly of a histiocyte, that is called a globi. The globi is for all this bacteria in a histiocyte. And you also have other terms that can be used in Hansen's condition. You can call these Virchow cells or Lepre cells. And those are another name for macrophages with numerous amounts of bacteria in it. You can see that in a regular H&E, the bacteria will just look blue-gray. unfortunately. For you to see the outline of gram-negative bacilla that you would see in Hansen's, you have to do your phyte stain, and then you can see the red, gram-negative bacilli. But in H&E, it's just going to look like this blue-gray, and these are like lobi. So very interestingly, this is Hansen's with a lot of bacteria. So this is probably on the spectrum, as you know, for Hansen's, when you have lots of bacteria, it usually denotes a poor immune system. And so there's a lot of bacteria around, whereas people who have more intact immune systems have a lot of histiocytes, and it's very granulomatous, but it's polycybacterial or very few bacteria. This is a great example. So please take a look at this color, take a look at where these are found, and again, found in the belly of these histiocytes. A great, great example of Hansen's disease. I'm going to come out again so you can see the faraway picture of these granulomata in Hansen's disease. Now, number 8 is not a very common condition at all. This is a punch biopsy. I think they did a wonderful job getting to where the action is, because you can see that in this punch biopsy that the action is occurring down deep, right here, deep in the fat. This is a lobular panniculitis of sorts, so we want to look down here where the action is. This patient could have presented, let's say, on the lower legs with nodules, painful nodules, and draining nodules, and so you would want to, of course, biopsy this. Now, from afar, it looks like this is truly infiltrating the fat. And there's a combination of single or mononucleated cells, but then there's also some very strange large cells. So let's see if we can look at some of the large cells in the specimen. And yes, I'm going to go very high magnification to try and show you what's happening here. So do you see cells like this? Cells like this? Cells like this. Let's look around and look for some more. Right down here. I think they're just fabulous. Look at this cell here. I'm going to go ahead and shine on this cell here. There's so many. I mean, honestly, this is just a fantastic example. All right. Is this as high as I can go? That's as high as I can go. Look here, 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 here. Do you know what these cells are? These are called beanbag cells. These beanbag cells are cells that are filled with inflammatory cells. They could be lymphocytes. They can be neutrophils. They can be actually even erythrocytes. These will eat those up. And unfortunately, they take them up into their lysosomes and they grind them down. And so you see debris. You see how there's little pieces of cells in here? So what's happening is these histiocytes are gobbling all these inflammatory cells up. These are beanbag cells, and the condition is called cytophagic histiocytic panniculitis. Now, this is really, really scary when you see it, because although it can represent a post-inflammatory condition, this is a spectrum. This could also be representative of a more multi-systemic fatal process where you have hemorrhagic diathesis and hemophagocytic syndrome. So this could be okay, or it could be really bad. So if you see beanbag cells, again, these large cells eating up the inflammatory cells, you have to look for lymphoma. Be Hodgkin's lymphoma. It could be it could be one of those panniculate-like T-cell lymphomas. So you must do your due diligence and go ahead and look for those things. Of course, the clinical picture should be helpful, but these are beautiful beanbag cells, and this particular specimen is just chock full of them. See, this one is beautiful. Let me just bring this one into the middle. You see that? A histiocyte with inflammatory cells and broken down debris. And over here, another histiocyte, is that oval nucleus, and these are the inflammatory cells within. Again, it's showing that it's actively eating them up and breaking them down. Let's go to number 9. I am excited to show you these large cells in this condition. All right, so this is a very large punch, or it could be an incisional of a lesion. Now, This condition that this is going to represent usually presents with fever and what they call large or massive lymphadenopathy. It doesn't have to involve the skin, but it can involve the skin. Sometimes it involves predominantly the skin, but as you can see, this is a nodular development, a nodular proliferation of cells going from here to here, here to here, all the way across the specimen. Even from this magnification, you see light cells. Again, light cells typically mean that you have larger cells or cells with some cytoplasm in it. And then you have these darker areas, which often are lymphocytes or cells with very little cytoplasm. So let's take a look at what cell types we're looking at here. I'm going to move over to this side. And what you can see here even is already perhaps a foamy appearance to those histiocytes. You're all familiar with foam cells now. And so I want to show you here, and let's look at this area. This is a foam cell again. So foam cells are in this entity. But what else do you see? Of course, big cells. So I'm going to show you. I think this one right here is maybe a good example. Let's go a little closer, and I want to show you. This is a proliferation full of foam cells. And some of these foam cells have gotten quite large. So this is the nucleus. And look at this large cell here. And inside the cytoplasm of these large cells are inflammatory cells as well. You can see here, 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 here. But these cells, do you recognize that these cells are relatively unfazed? They're not being broken down. They're just, as we say, passing through. They're passing through the cell. And this is called emperipoiesis. When you have large foamy histiocyte with a lot of inflammatory cells within the cytoplasm, they're not being broken down, they're not in lysosomes, they're just passing through. This is emperipoiesis. So far I've shown you this tumor has very big foamy cells of different sizes, regular and large, with emperipoiesis. And then a helpful feature is to look very carefully for what type of infiltrate do you have. You do have lymphocytes scattered about, but what you have a lot are these. And everybody should hopefully recognize this is a plasma cell. Plasma cells have eccentric nuclei, sometimes a little clock-faced nucleus with little collections of chromatin pattern along the edges, a condition like this, which has large skin nodules with foam cells and lots of these plasma cells, are characteristic of the condition called Rosai-Dorfman. They sometimes on exams will show you a close-up like this. They'll say, patient presented with large nodules and massive lymphadenopathy, and this is the pathology. You see foam cells, you see plasma cells. Already you're thinking Rosai-Dorfman. You see large cells with inflammatory cells within it. And this, again, is another just great example of this entity. See these inflammatory cells within the cytoplasm of these foamy large histiocytes. This is a very interesting condition. It actually stains for S100, not for CD1A, but S100 and CD68. So doing those special stains can help you as well if you're having difficulty making this diagnosis. Over here, just showing you lymphocytes. And that's what you see from afar, causing these darker areas. And then what you see causing these paler areas are these foamy histiocytes. Right. This is just, another great example of Rosai-Dorfman, or of a condition here. And I'm going to decrease the magnification to remind you that these are big nodules, right? It's just chock full of inflammatory cells. All right. We're going to number 10. 10 is a treat. I have to say it's a treat because I've never seen this clinically, but I've seen the pathology just a few times. So I was very thankful because I wanted to show you this one, that they found a case of this. And so this is looks like a large punch biopsy, another really great punch. See how deep they got with this punch biopsy. You see the action in this case is in the papillary reticular dermis. And you see here's the epidermis, and here's the inflammatory portion of the dermis. So let's look carefully at this condition. We're going to go a little closer. Even from here, do you not see these large multinucleated cells? And in the background of this are large mononuclear cells. And this is a condition called granulomatous slack skin syndrome. Granulomatous slack skin syndrome is characterized clinically by someone who already typically has a diagnosis of mycosis fungoides. Matter of fact, these people have already usually patches or plaques of lymphoma, sometimes even tumors or nodules. And within the patches of mycosis fungoides, you will see the development of these large pendulous structures. And typically they're going to be found like in the axilla or the groin area. When you look at what is causing most of the inflammation, you see that they are large atypical lymphocytes. They could be a little bit notch or cleaved. They're just a little bit atypical, a pretty monomorphous collection of lymphocytes. And if you don't know, of course, you could do immunostains to look at it, right? But these are a sea, I call it a sea of atypical lymphocytes. And then within the sea of atypical lymphocytes, let's come over this way, we saw these. Look at these cells, they're huge. Again, I feel like they're trying to have a purpose. And they're trying to come in here and react to this atypical monomorphous population of cells. And you have these giant multinucleate cells. Sometimes you have 50, 60 nuclei in some of these multinucleate giant cells. Now, I looked very carefully and I couldn't see it, but in this condition, these multinucleate giant cells, not only are they trying to eat up these atypical lymphocytes, right? So you do see the lymphocytes within the cytoplasm of this multinucleate giant cell. Well, what they're trying to do is not only eat that, but typically they eat all the elastic in the area too. So sometimes you'll see elastic fibers with the lymphocytes in these large multinucleate giant cells. If you do an elastic stain in this area, if you do an elastic stain, it's typically showing you that all the elastic fibers are gone. And so that is probably why in the clinical appearance you see pendulous structures. They've lost their elastic fibers and now they're just hanging loose, like the back of an arm. An older lady, just loose and floppy. So this is such a rare condition, but I just love it. And there's nothing else that looks quite like that. This is granulomatous slack skin condition. All right, we only have 3 more to go, so hang in there. All right, I love this tumor too. As you can see, this is a tumor that has a well-defined, well-circumscribed collection of cells. Now, I have to say that this has been shelled out, so you can't tell necessarily where it came from, but this typically occurs on the hands, particularly the dorsal aspects of the fingers. And so sometimes a clue to what this is going to be that the overlying epidermis shows acral skin. So that sometimes can be helpful. But in the absence of that, you can still figure out what this tumor is. So this is a large lobulated tumor that was shelled out, and it's full of mononuclear cells. And you can see that these mononuclear cells are scattered about, but again, intermixed amongst these cells are some larger cells. Let's take a look at these larger cells. Let's see, I want to look over here. See, they're coming up. See these larger cells? All right, let's go higher magnification and look at them. Now, I like these larger cells because if you look at the cells we looked at before, most of them have very smooth edges, like the foam cells, very smooth edges, or the multinucleate giant cell smooth edges. Now, Rosai-Dorfman, it's hard to see the edges. It's foamy, but in these cells, the edges of the multinucleate giant cell is much more spiculated. So let's see if we can find one that's a little bit more spiculated. I don't know if you can see, they almost look scalloped, right? So they almost look scalloped. You can see that these multinucleate giant cells have cells molding against them, so they looked more spiculated or scalloped. And that's how osteoclast-like giant cells look. You know, osteoclast giant cells trying to eat up bone, and they tend to stretch along the bone and be very long and spiculated. Well, this is the entity the only other entity that has these osteoclast-like giant cells, where other inflammatory cells may mold against them. Let's see if we can look over here at some more examples of these large multinucleate giant cells. In the background of these cells, you see they're kind of round, oval epithelioid cells. I'm going to come around to this side. This is a great one. Let's look at this one. This one looks very speculated, doesn't it? Look, a little points here, point here, or scalloped here, where the cells mold against them, you see? And that's an osteoclast-like giant cell. When you see that in a mononuclear population, and these are kind of epithelioid appearing cells, then you might want to think of a giant cell tumor of tendon sheath. And that is what this entity is. These are CD68 positive. They don't know actually the etiology of these cells, whether it is fibrohistiocytic or whether this is actually related to osteoclast-like cells, but very, very characteristic. Usually look all very similar, look like this. And again, let me show you that they're very well-defined nodules. You can move them if you've ever seen one clinically. You can move them, and they're sometimes attached to the tendon, right? Attached to the tendon. So you could possibly remove them yourself, or sometimes I have ortho remove them just because the attachment, I don't want to get too deep and mess anything up, of course. But I think this is a great example. So when you have time and you want to say, well, wait, what are these osteoclast-like giant cells of a giant cell tumor of tendon sheath? Just pull this up again and look at this example. I think you'll find it tremendously helpful. Okay, number 12. I'm going to turn this one this way, and we're going to look at this nodule. Again, this is another condition which is producing a nodule of the skin where you have a dermal proliferation of cells. And this could be singular, and this could be multiple. So let's look at what I'm talking about here. Let me go to this top one. I really like this example. It's a little blue, but you still see the characteristic findings of this tumor. The epidermis pretty much fine, is being pushed up, so there's some flattening of the rete here as this tumor is pushing and creating a nodular appearance. And when you look, you see here, there's definitely a lot, maybe sheaths of large cells. You can see them because, again, they're pale, but also background of some darker cells that have less cytoplasm. I think you can really see that these cells are different from any of the other large cells we've looked at. These cells have a very interesting cytoplasm. So I'm going to pull this up, pull this a little bit closer so you can see what I'm talking about. So many examples, it's hard to choose which one I want to focus on. I'm going to maybe go to this one here, right in the middle. Just a smaller example, but I think it's a good one. Let's go really close and look. These cells over here, less cytoplasm, they're mononuclear cells, histiocytes, right, mostly. But here, look at this giant cell. When you see a giant cells that have two tones to it, this is the darker tone and this is the lighter tone. You see that? Many of these cells exhibit that two-tone cytoplasm. When you see a two-tone cytoplasm, there's only one thing we call two-tone cytoplasm, and that is the cells composed or that are found in a reticulohistiocytoma. Sometimes these will be a little bit more on the pinky side, and then you can call it like a dusty rose color, but I think maybe you can appreciate that like in some of these cells that could look dusty rose. Or some people also like to describe this grainy nature as a ground glass. So some people will say that the cytoplasm looks like ground glass. The cells can be singular, but when you get these big cells, they're typically multinucleated. You see this has 3 nuclei, or look at the size of this one, multiple nuclei in a multinucleated cell with two-tone cytoplasm. So if this person has a singular lesion, one nodule, you can call it a reticulohistiocytoma. But if you have someone who has multiple of these nodules showing you multiple reticulohistiocytosis, they could have more problems, right? So in that case, these cells aren't necessarily representative of a good thing. It's a bad thing, right? And in this case, the individual could be at risk for a mutilating arthritis, right? That's our board match. Multicentric reticulohistiocytosis associated with mutilating arthritis. But they also can be at risk for underlying tumor or cancer in maybe 10% of people. It's not too unusual in this condition to have some other inflammatory cell types, like some eosinophils scattered about, or lymphocytes. But the key and the clue to this diagnosis is going to be these two-toned histiocytes. Okay, so I love this example. Again, beautiful example of reticulohistiocytosis. I think this was called a reticulohistiocytoma. So I'm assuming this was a singular lesion in an individual. Look, a little bit of nice shadow here. But look carefully at those cells if you want to compare them again across the other giant cells we've looked at today. And finally, we're going to end with this great example of a different large cell type. Now, this cell is not a histiocyte. Nope. This cell is of neural origin, at least that's what we believe. So let's look at this a little closer. This tumor has diffuse proliferation of large cells. You can see again, filling the dermis from top to bottom down to the fat. And we're going to go closer and look at these large cells. I'm going to take my time, don't want to hurt you, that you see here, filled with large cells. Now, of interest, when you have this tumor like this, you can have overlying epithelial hyperplasia. Sometimes like this, it is mild epithelial hyperplasia, and meaning there's the extension of the reed here. Sometimes in this tumor, it can be quite remarkable and look like PEH or pseudo epithelial hyperplasia, and even look like a squamous cell, well-differentiated squamous cell carcinoma. But in this case, just mild psoriasiform hyperplasia over this tumor. And when you look at these cells, you start to realize it's not like any of the large cells you've seen today, is it? These cells are very large, multinucleated, but very much more of a pink cytoplasm, or I always think it's kind of like a mauve color. And when you look even closer, all right, I know we're going to high magnification, we can see that it is a granular appearance to the cytoplasm of these cells. The granular appearance helps identify this as a granular cell tumor. You can see that here's your nucleus, here's the large cytoplasm with large granular appearance. This is a granular cell tumor. If you look at this granular cell tumor, you notice some little pink bodies. Right? I'm going to show you some of them. Like for instance here, that one's a tiny one, or here. And there's actually quite a few really good examples of these little pink bodies. I'm going to focus on this one right here. You see that? It's within the cytoplasm of this large granular cell. And this has a special name. This is probably a phagolysosome, but it is called a pustulo-ovoid body of Milan. We love this. Pustulo-ovoid body of Milan, which are these little pink bodies found in the granular cytoplasm of these large cells of a granular tumor. So this is called a granular cell tumor. But they believe this origin is unlike the origins that we were talking about earlier. They believe that these cells are derived from Schwann cells and are S100 positive. They're not sure, but that's what we believe, that these are neural tumors, again, a Schwann cell origin staying with S100. These were initially found on the tongue, and actually is very commonly found on the tongue, but as we know, it can be found in other locations as well. I remember we had one of these found on the toe uniquely, and actually they did a biopsy with just a shave, and they thought that it was a squamous cell tumor. And though they went to Mohs surgery, and the Mohs surgeon took his first layer and said, whoa, wait a minute, there's some large granular cells under here. And he correctly identified that what he was doing was not mosing a squamous cell carcinoma, but instead a granular cell tumor, and called us promptly. What a great diagnosis, right? A great catch. But usually, again, these are found on the tongue, and these are neural tumors. Because of the mauve color, sometimes I call these marvelous tumors, and I hope that they are marvelous too. Well, that ends my session on giant cells. I think you can see there's a wide spectrum of giant cells. I could have added probably 15, 20 more. Some are to the benefit of the patient, and some of them aren't. It could be a nuisance, cause tumors, or even be life-threatening. So I hope you spend time to look at these and find the differences and similarities between this entity and look for other giant cells to study. Thank you so much, and have a great afternoon or now evening. Bye-bye.
Thanks so much, Sandra. What a wonderful presentation as always. And again, if you have any questions at all, please feel free to email me directly or email Sagis, education@sagisdx.com. I can also forward any questions you might have to Dr. Osswald. So I hope everybody has a great evening, and we'll see you soon. Thank you.